Emerging therapies in Parkinson's disease, current status and potential role of agents targeting alpha-synuclein. I'm Dr. Stuart Isaacson, Director of the Parkinson's Disease and Movement Disorder Center of Boca Raton, and Clinical Associate Professor of Neurology at FIU Herbert Wertheim College of Medicine. These are my faculty disclosures. This CME program is provided by North American Center for Continuing Medical Education, LLC, an HMP global company, and is supported by an educational grant from Biogen. Our learning objective is to describe the evolving understanding of the role of alpha-synuclein in the pathogenesis of Parkinson's disease and how it is informing the development of potentially disease-modifying therapies. Alpha-synuclein has been implicated in Parkinson's disease in a number of different ways. Lewy bodies are the pathological hallmark of Parkinson's disease, and the alpha-synuclein protein is a major component of Lewy bodies. Alpha-synuclein is also seen in Lewy neurites and neuritic processes emerging from these neurons throughout the neuroaxis. Accumulation of alpha-synuclein thus is a predominant neuropathological feature and seems to follow the progression of a disease from a prodromal phase into a motor and non-motor phase. Alpha-synuclein as an extracellular target during pathogenesis has been proposed. There seems to be a caudal to rostral progression and staging of the disease, demonstration of transfer from cell to cell in animal rodent models, and in human transfer from a Parkinson's disease brain to fetal tissue cells implanted years prior have been demonstrated. The variety of these propagation models give hope that intervening with alpha-synuclein, trying to reduce its presence in an aggregated form and trying to reduce its cell-to-cell propagation may have disease-modifying therapy abilities. Alpha-synuclein contains three regions: an N-terminal repeat region, an NAC domain region that stands for non-amyloid component, and an acidic C-terminus region. The genetic mutations, triplications, and duplications are seen in the N-terminal repeat region, and the mutations are indicated here, A30 and A53 residues. The N-terminal region acquires an alpha helical secondary structure upon binding to membrane lipids, cell membranes, vesicular membranes, ER membranes, mitochondrial membranes. The C-terminal region is highly flexible and mainly unfolded. And the hydrophobic NAC region may be important for alpha-synuclein aggregation. Anti-alpha-synuclein strategies for disease modification can be thought about in three main ways. Anti-aggregation molecules that reduce the aggregation propensity of alpha-synuclein. Active immunization, where epitopes are delivered and the body raises antibodies against pathological aggregated forms of alpha-synuclein. And passive antibodies that are developed and administered to patients to reduce targeted epitopes of alpha-synuclein in the different regions of the protein. An alpha-synuclein misfolding inhibitor is being developed named UCB0599. This acts by targeting an early propagating step in the formation of alpha-synuclein toxic protein aggregates and inhibits alpha-synuclein misfolding. It has recently entered early phase human trials. Active immunization, also known as specific active immunotherapy, is being developed as well. This active immunization uses what's been called epitope technology, where amino acid sequences that mimic the epitopes of pathogenic forms of proteins are modified by mutating the original amino acid sequence. And then using these amino acid sequences, they're coupled to a carrier and are formulated with an adjuvant to enhance an immune response, so that when they're administered subcutaneously by injection, they're able to stimulate the generation of antibodies produced by the body against pathogenic forms of alpha-synuclein. This has been evaluated in a phase 1 program. PD-01A is a specific active immunotherapy with a short peptide formulation that's targeted against oligomeric alpha-synuclein. In a phase 1 randomized study, the safety and tolerability of this molecule was assessed in patients with Parkinson's disease. It seemed to have demonstrated tolerability with adverse events with fatigue, headache, myalgia, muscle rigidity, and tremor. The geometric group mean titer of antibodies against the immunizing peptide PD01 increased from baseline to week 12 in 2 doses tested. The antibody titers tended to return to baseline over 2 years, but could be rapidly reactivated after booster immunization from week 116 onwards, reaching a geometric group mean titer up to 1 to over 20,000. In this phase 1 trial, it was concluded that repeated administrations of this peptide was safe and well tolerated over an extended period. That specific active immunotherapy resulted in substantial humoral immune response with target engagement. Phase 2 studies are now planned. Let's turn now to thinking about passive antibodies, monoclonal antibodies that are developed that can be delivered to patients developing or having Parkinson's disease. There are a number of molecules that have been identified and are under study. Some are listed on this slide. Prasinezumab targets the C-terminus, which is exposed in the aggregated forms of alpha-synuclein. Cinpanemab targets the N-terminal region and is involved in alpha-synuclein fibril formation. A drug, ABBV-0805, is another monoclonal antibody that selectively binds and eliminates oligomers and protofibrils of alpha-synuclein. And other monoclonal antibodies are also under study, as identified on this slide here. Let's discuss in detail both prasinezumab, the C-terminus antibody, and cinpanemab, the N-terminal region. Reducing C-terminal truncated alpha-synuclein by immunotherapy was shown to attenuate neurodegeneration and propagation of alpha-synuclein in a number of Parkinson's disease-like rodent models. It has been demonstrated in some studies that C-terminus truncation and propagation of alpha-synuclein can play a role in pathogenesis and propagation. And antibodies to this region may attenuate both synaptic and axonal pathology, reducing the accumulation of C-truncated alpha-synuclein and perhaps rescuing nigral neurons and their fibers that project to the striatum. The cell-to-cell propagation of full-length alpha-synuclein was reduced in one cell-based system studying this type of antibody to the C-terminal region. And results obtained after lentiviral expression of alpha-synuclein suggested that antibodies might actually block a protease site of capain-1 and block the extracellular truncation of alpha-synuclein in this fashion. These results taken together demonstrate that antibodies against the C-terminal region could have a benefit in Parkinson's disease progression. Prasinezumab is an antibody that has been studied and can bind to the C-terminal region. It's been studied both in vivo and in cellular models. It reduces the buildup of intracellular alpha-synuclein pathology and seems to protect neurons and block cell-to-cell transmission of alpha-synuclein. It co-localizes with intracellular lysosomes and autophagosomes. It can protect synapses and reduce gliosis, and in an animal model ameliorated motor and cognitive behavioral deficits. The mechanism of action of prasinezumab seems to be by preventing the cell-to-cell transfer of pathological alpha-synuclein, and in this way, both reducing neuronal toxicity and slowing disease progression. This monoclonal antibody is a humanized IgG1 antibody that binds aggregated alpha-synuclein with 400 higher selectivity over monomeric alpha-synuclein. Studies demonstrate that it's able to enter the CSF in a dose-dependent manner and can be demonstrated there. In a recent 52-week multi-center randomized double-blind placebo-controlled trial called PASADENA, this antibody was evaluated in 2 doses, a low and high dose, against placebo in part 1. And then patients were then allowed to enter a extension phase where all received low or high dose antibody administration. In this study, the primary endpoint was a change from baseline to week 52 in the total MDS-UPDRS scale of the sums of parts 1 and 2, which are the activities and experiences of daily living, and part 3, the motor examination, a validated scale in Parkinson's disease. Many secondary endpoints were also evaluated, as depicted on this slide. Baseline characteristics revealed an early population of patients who are approximately 60 years of age, 70% male, with the average disease duration under 1 year. About a third were taking a selective MAO-B inhibitor. Their total MDS-UPDRS total scores were in the low 30s. Their Hoehn-Yahr stages were 2, and some more patients were in stage 1. The primary endpoint was not reached and not met, demonstrating no significant difference between patients receiving low dose, high dose, or placebo arms. Although the primary endpoint was not reached, it was demonstrated to have tolerability across both the low and high dose arms. However, a number of secondary endpoints give hope. Looking specifically at the part 3 ratings, the motor examination, we can look at both the site rating and the central rating and see separation from placebo that was confirmed at the central rating. Looking at a time to worsening of motor functioning, predefined as more than 5 points on part 3 motor examination, we saw a reduced risk on time to worsening. Looking at specifically bradykinesia, as well as a digital motor score, we saw separation from placebo as well between baseline and week 52 in both the low and high dose arms. Other secondary endpoints also give hope, including MoCA, a measure of cognitive function, the overall patient global impression, the clinical global impression, and importantly, on the DAT-SPEC change in dopaminergic terminals. On exploratory endpoint, there was reduced decline in cerebral blood flow in the putamen. So in summary, this phase 2 PASADENA study exploring prasinezumab in early Parkinson's disease failed to meet its predefined primary endpoint, but demonstrated hopeful differences from placebo on a number of secondary endpoints and was demonstrated to have safety and tolerability. Further studies are planned and beginning to see if we can identify in a primary endpoint fashion an improvement on disease modification with this monoclonal antibody directed at the C-terminal region. Let's turn now to another monoclonal antibody, Cinpanemab, also known as BIIB054, that is an aggregate selective human-derived alpha-synuclein antibody. This is an antibody that binds to the N-terminus residues 1 to 10. And it's highly selective for aggregated forms of alpha-synuclein with at least an 800-fold higher affinity for fibrillar versus monomeric recombinant alpha-synuclein, and also a strong preference for human Parkinson's disease brain tissue. Cinpanemab discriminates between monomers and oligomeric fibrillar forms of alpha-synuclein based on its high avidity for aggregates. And this is driven by a weak monovalent affinity and also fast-binding kinetics. And in efficacy studies in a murine model, in 3 different murine models that had intracerebrally inoculated preformed alpha-synuclein fibrils, this monoclonal antibody treatment with Cinpanemab attenuated the spreading of alpha-synuclein pathology, rescuing motor impairments and reducing the loss of dopamine transported density in dopaminergic terminals in the striatum. In a phase 1 study evaluating single ascending intravenous doses of Cinpanemab in healthy volunteers and also in people with early Parkinson's disease, safety measures, MoCA cognitive screen, serum levels, and pharmacokinetics, as well as the presence of anti-Cinpanemab antibodies, was evaluated. In the healthy volunteers, these were healthy participants aged 40 to 65 who received doses that were found to be well tolerated. Side effects did include headache, dizziness, pain, or skin rash related to the infusion. The half-life of this monoclonal antibody was 28 days, and the CSF to serum ratio was 0.2% at all doses, and a maximum concentration in blood was found to be dose proportional. Looking at the group of early Parkinson's disease cohort, these included 13 men and 5 women. They were aged 47 to 75. 9 were untreated, 5 were on levodopa, 2 on razagiline, and 2 were on both levodopa and razagiline. This cohort received a single infusion of varying doses, and the pharmacokinetics were identified to be similar to those in healthy volunteers, with a 33-day serum half-life. There was a 3-fold higher plasma concentration in the high versus low dose group, and 0.4 and 0.3% reached the CSF in the high and low dose, respectively. None of the patients developed anti-Cinpanemab antibodies. Cinpanemab formed plasma complexes with alpha-synuclein in both cohorts. Both doses formed similar amounts of complex, suggesting saturation of blood synuclein with antibody. Cinpanemab is more selective for aggregated than soluble alpha-synuclein, but at high doses can bind soluble protein. No serious adverse events were reported. And importantly, Cinpanemab was found to have a favorable safety, tolerability, and pharmacokinetic profile in both healthy volunteers and participants with Parkinson's disease. Based on the safety and tolerability in the phase 1 trial, a phase 2 study of the anti-alpha-synuclein antibody Cinpanemab in Parkinson's disease was begun, also known as the SPARK study. In the SPARK study, there are 2 cohorts, an initial cohort that received intensive PK monitoring, and then cohort B, that all told over 350 patients were enrolled in this study. At randomization, they were randomized to one of 4 arms, a placebo arm, and then 3 different doses of Cinpanemab. Over the first year, this will be a double-blind placebo-controlled trial with the primary analysis at week 52. Subsequent to this, patients will remain dose-blinded, but all patients will receive active antibody. Enrollment began in January 2018 at over 80 sites in 9 countries and has already been completed. In this study, about half the patients were enrolled in North America, about 44% in European Union, and about 6.5% from the rest of the world. The average age was 60 years of age, 70% were male, over 90% were white. The median time since disease onset enrollment was 1.5 years, with a median time since diagnosis of about half of a year. The baseline characteristics of the participants of the SPARK study are remarkably similar to the PPMI cohort, which will allow a lot of information to be compared. In this study, their overall MDS UPDRS scores were about 32, similar to what was seen in earlier studies. And this entailed a score of about 23 on the Part 3 motor examination. Many patients were in the early stage 1 or 2 of the Hoehn-Yahr staging system. This phase 2 study has a primary endpoint to evaluate for dose-related safety, both AEs and SAEs. Other safety assessments are planned, including neurological and physical examinations, laboratory and ECG, MRI, and vital signs. A number of secondary endpoints will explore potential disease-modifying benefits, primarily looking at the effect of Cinpanemab on the integrity of nigrostriatal dopaminergic nerve terminals in year 1 using SPECT ioflupane scanning. There'll also be assessment of the PK profile of this monoclonal antibody and evaluation of its immunogenicity. In summary, the SPARK study, the phase 2 study of Cinpanemab in Parkinson's disease, aims to identify whether this human-derived monoclonal antibody can have a disease-modifying effect and be safe and well-tolerated. We know that aggravated alpha-synuclein is a major constituent of Lewy bodies and seems to play a central role in the progression of Parkinson's disease. Cinpanemab preferentially binds to aggregated forms of alpha-synuclein that may be propagated throughout the neuroaxis. In this phase 2 study, patients who administered varying doses of Cinpanemab will be compared to placebo to identify its safety and tolerability, its pharmacokinetics and pharmacodynamic effects, and also to look at the effect on SPECT imaging of dopamine transporters as a measure of neuroterminals in the striatum. Since the demographics at baseline are quite similar to those observed in the PPI trial populations, they'll allow further comparisons to be made. Remarkably, recruitment to this trial was completed ahead of projected timelines. The trial is ongoing, and hopefully results will be forthcoming. So there's a lot of work that's been done in trying to understand the role of alpha-synuclein in Parkinson's disease and identifying therapeutic strategies to try to interfere with alpha-synuclein toxicity and propagation and progression of Parkinson's disease. We discussed a number of these in this module, and hopefully it was informative, and I appreciate your attention. Thank you.